So that brings us, I think, formally to the end of the AGM. I'm afraid not much of a presentation that was, and this is not much of a formal presentation either, but it's a very, very important one. And it sort of picks up where our student prize has led us, which is to understand evidence. Where's the evidence? How much can we rely on it? And these are questions which, as Susan was saying in her introduction earlier, in her report, have as much relevance today as they've ever done, if not even more so. There's more evidence available for people, certainly more information available for people than any ever before in human history. And somehow, instead of uniting us, it's come to divide us. And we don't need reminding that how much it's used now for propaganda. With social media, we can write our own scripts, and we can bask in the reflected glory of our own ideologies and ideas without having them contradicted. And the internet is full of a lot of nonsense. So we really do need people who can tell us how to chart our way through this minefield. We all know we've been told we've had enough of experts, but actually it's very, very difficult, even if you listen to the experts, because if we're going to be guided by science, which of the scientists are we going to be guided by? Is it people like Carl Hennigan, the Centre for Evidence-Based Medicine at Oxford, and people like Sunetra Gupta at Oxford as well, or people like Chris Whitty and Sir Patrick Vallance? So, thank heavens for this year's prize winner, who's one of the people out there who is helping us chart our way through. A statistician who makes sense of statistics. She spent her whole career checking out what works and what doesn't in healthcare. She herself was a big cheese at Oxford. She's now, of course, a big cheese at the Royal Statistical Society. You should have seen her CV, which has been circulated to everybody. She's now head of statistical research at PHASTAR, the big medical research consultancy. But for me, and I think for all of us at HealthWatch, most importantly, she is a proselytizer for good evidence to anybody who cares to listen, not just at conferences or in journals, but in schools, in theatres, and pubs, I think, and radio programs, including my favourite one, More or Less, on television, including a program I used to present, Watchdog. She is a wonderfully worthy award winner, Professor Jennifer Rogers. Jennifer, congratulations, even if I can't pronounce your name. Someone was saying earlier, we normally have glasses of wine at the HealthWatch Awards, and obviously without a glass of wine, we're becoming increasingly inarticulate. Jenny, welcome. Thank you very much. Congratulations. I wish I could give you the award in person, but anyway, we're all very much looking forward to hearing from you. And I gather your mum is tuned in as well, so that she can hear you too.
Yes, that's the joy of doing it online, I think, this year, that actually people who wouldn't normally be able to tune in are able to watch. So no, just a huge thank you very much for the award. You know, looking at the other people who have won it previously, I'm humbled to be in such amazing company. So I'm just going to share my slides. Fine. Yeah, so yeah, a huge thank you. As I said, I'm so humbled. I've got to say a big thank you as well to the Royal Statistical Society, where I've been, I'm just coming to the end of my 4-year term as Vice President for External Affairs, and I've had the opportunity to do lots of policy and public engagement work and through that. And a big thank you as well to my bosses at PHASTAR, my MD and CEO, who allow me to have the time to spend doing all this interesting stuff. I've always felt that, you know, public engagement is such an important part of my job, and I've always strived to be, you know, an ambassador for bringing statistics to the masses. And it's not just because I love statistics, I do, and I'm, you know, obviously very passionate about it. But I think it's so important, and I think public communication is so important. And I'm just really honoured to be here on World Statistics Day, which only happens every 5 years, and in particular this year, that I think has been very, very challenging for medical statistics. So why do I think public communication of statistics is important? Well, every single day we're bombarded by news headlines that tell us what we should and shouldn't be doing, how we should be living our lives. But sometimes this data and these headlines can be misleading, and our own personal experiences can skew our interpretation of it. And I think it's really important to give people the tools that they need to be able to ask the right questions of statistics that they see every single day. And I want to start out by talking about the humble bacon sandwich. Now, if headlines are to be believed, bacon is one of the worst things that we could be eating. It's higher risk of all sorts of different types of cancers. Here we've got a headline that says a daily fry-up boosts cancer risk by 20%. A shocking sounding headline that actually caused bacon sales to plummet. But is it actually something that we really need to be worried about? Now, crucially, when we see headlines like this, what we're seeing is something called relative risk. Now, we call them relative risks because they only tell us what the risk is in one group relative to another. I know that if I eat bacon, my risk of pancreatic cancer is increased by 20%. But what I don't know is what actually my risk of pancreatic cancer is. Now, for that, I need what are called absolute risks. So how do we take these relative risks that we see every day in the newspapers and turn them into absolute risks that are actually useful? Well, first of all, I'd need to know what chances of getting pancreatic cancer. And according to Cancer Research UK, we have a 1 in 80 lifetime risk of pancreatic cancer. So what does that mean? That means if we were to take 400 individuals who didn't eat bacon, we would expect 5 of them to get pancreatic cancer. Now, if we take a look at our headline again, we see that a daily fry-up boosts cancer risk by 20%. So 20%, that's a fifth. And what's a fifth of 5? It's just 1, meaning that my risk of pancreatic cancer goes from 5 in every 400 individuals to 6 in every 400 individuals. So it's only an extra 1 person in every 400. So this headline saying our daily fry-up boosts cancer risk by 20%, whilst it might sound really scary, in actual fact, a headline that read increases your risk by 1 in every 400 probably wouldn't sound anywhere near as shocking. Now, 2020, I think, has been a really interesting year for statistics and for medical statistics. I don't think I can ever remember a time where statistics have been more in the spotlight. And that is, of course, due to the coronavirus pandemic. You know, back in the midst of the first wave, when we were all in lockdown, we were having daily government briefings that were presenting data that were being updated on a day-to-day basis. We've been absolutely bombarded with all of this information, and statistics has really had its chance to shine. You know, being World Statistics Day, you know, Tim Harford, he said on Twitter today, all around us, statisticians and other hero geeks are painstakingly gathering and analysing the numbers we need to understand what is happening all around us. I don't think that has ever been more true than when thinking about coronavirus. Now, we've got all sorts of really important questions that we want to get the answers to. You know, how does it spread? Who's most at risk? Where is it now? You know, what treatments are safe and effective? We're seeing this absolute flood of so much data, and never has there been more important time for people to use this published data to inform decisions. But how do we wade through everything that we're seeing? You know, this is a new disease where everybody is susceptible, and the landscape is just changing so constantly. How do we answer these key questions? And I want to take a look at just some of the challenges surrounding answering some of the most seemingly easy of questions to answer. And I think one of the key things that you might want to ask yourself, fundamentally, the first question when thinking about coronavirus is, how many COVID cases are there in the UK? Seems like it should be a relatively straightforward thing to try and answer, but that's just not the case. Even this itself is such a complicated question. Now, we're used to seeing these daily reported number of cases, and quite early on we got used to statistical concepts such as 7-day moving averages to smooth out this noisy data, this granular level that's got all these different fluctuations. But how do we use this information to try and inform how prevalent coronavirus might be in the general population? That's really what we're interested in. Are cases in the general population going up or down? In the general population, are we any worse off now than we were in March? Looking at these reported cases, we can answer those questions really easily. But these reported cases, we know that they're an underestimate of the true number of cases in the population. Can we use this information, though, as a proxy? Is it a good way to estimate what's really going on in the general population? Can we, for example, say, well, we know that we don't capture all of the coronavirus cases out there, but let's say that we capture 10% of them, nice, just round figure. Does that mean that the true prevalence in the UK looks something like this? It'd be a really ideal scenario if that was the case. But unfortunately, as I said, it's an ever-changing landscape and the parameters are changing all of the time, which means using this information about the reported number of cases to infer population-level prevalence is a really difficult thing to do. One of the easiest things to think about is actually testing. So even the way that we test people has changed so much over the last 6 months. So this is just the number of tests that have been carried out. Can we try and use this relationship between the number of tests being carried out, the proportion of those tests that are positive, to tell us something about the prevalence? In general, if we think about what is the definition of prevalence, it is the proportion of the population who are positive. So it's the number of positive cases divided by the size of the population. In an ideal world, you'd be able to test everybody in the population, find out how many were positive, and you'd know what your prevalence is. But we just can't do that. We don't have the capacity to be able to do that. So can we use the information that we have on the number of tests that have been carried out and the number that are positive to tell us something about the prevalence? Now, there are a couple of really strong assumptions that you can make, which are very unlikely to be true. And I'm going to put, you can use the test data to tell you something about the prevalence under some very strong assumptions. Now, the first one is that you have 100% accuracy. That's not likely to be true. We're likely to have false positives and false negatives. You would hope that any good testing minimizes that, but it's not likely you're going to have 100% accuracy. If you want to use this test positive over the number of tests to estimate your prevalence, you also need to assume that you're testing a random sample within your population, which is not going to be true in this instance. We're not randomly testing people in the population to see if they have coronavirus. People are opting to have tests done because they have some reason to believe they may be positive. They may be exhibiting symptoms, or they may have come into contact with someone they know is positive. So we have some really strong assumptions here, which I know are not true, but I just want to try and use this relationship between prevalence, test positivity, and the number of tests, just to highlight how different the prevalence and the reported case curves can be. So it's just to give an indication as to how different the curves could look. So let's think about this in a little bit more detail. Let's say we have 100 cases, 100 positive cases, but we've done 1,000 tests. That means we have a 10% prevalence. If we have the same number of positives, but we increase the number of tests, our prevalence in the overall population actually goes down. So if we had 10,000 tests with 100 positives, it's a 1% prevalence. So what does this mean for the data that we've seen? So we have this data here, which is our reported number of cases, and we have this data here, which is our reported number of tests. Now I want to look at this area here, which was when we'd gone into lockdown and we would see a flattening of this curve in the reported number of cases. Now, our reported number of cases didn't seem to come down as quickly as it did in other European countries. We had this period of time where we just had this flatlining of cases. Now, does that mean that actually prevalence in the UK also flatlined? Well, no, probably not. Because if we look at the same period of time and we look at what was happening to testing over that period of time, we can actually see that there was a substantial increase in the number of tests being carried out. So we have a flatlining in the number of reported cases, but an increase in the number of tests, meaning that our overall prevalence in the UK actually probably did start coming down quicker than was suggested by the reported number of cases. If we also take a look at this ratio here between the number of cases being carried out, the number of tests being carried out and the number of positive cases, and we compare that to the ratio here between the number of tests being carried out and the number of positive cases, we can see that this ratio now in October is so much bigger than the ratio that we had in April and into early May, meaning that the prevalence now is probably actually much more likely to be lower now than it was in March, even though our reported number of cases is actually a lot higher. Now, as I said, we've got some pretty strong assumptions, but even with those assumptions, as I said, I wanted to just show you an example of how different these curves could be. So what I did was I did look at the ratio of the positive cases over the number of cases, and what would that mean for the underlying prevalence in the UK? And this is the shape of the curve that I've got. And we can see it's very different to the shape of the curve for the reported number of cases. We do see this reduction in the number of cases coming down a lot quicker than what is suggested by this flat line here. And we do see that our prevalence seems to be a lot smaller this time round than it was in the first wave. So that just goes to show just how much of an effect a different number of tests can have on that relationship between the number of cases reported and the true number of cases in the population. And it's not just the number of tests that have been changing. The types of people that we've been testing has also been changing. Who we've been testing has been changing. We have these different pillars of testing. And first of all, we started out with this pillar 1 of testing, which we can see here on this bottom plot. Now, pillar 1 of testing that takes place in hospitals and in public health England labs. And at the very start of the pandemic, that was mainly people who were being hospitalized because their symptoms were so bad. And at the beginning of the pandemic, these were the only people who we were testing. So there were a whole host of people in the general population who think they may have had a coronavirus and they weren't able to get tests. So we have a whole host of the population that we're actually missing. Or me, myself, I think I had coronavirus at the start of April. I was just told by NHS to sit at home and wait it out and self-isolate. I wasn't given the opportunity to have a test. But then we started testing the general public. So this curve here actually shows the sum of the pillar 1 and the pillar 2 testing. So this difference between the two curves is then just those having the pillar 2 testing. And we can see that pillar 2 testing has been increasing over the last 6 months. And pillar 2 testing, that's the testing of the wider population. So, the drive-in centres or the at-home swabbing and things like that. And even within this population, who we've been testing has been changing. The end of May, we introduced test and trace, meaning that our testing may have been more targeted than it was before. We started introducing national surveillance data where we were actually carrying out some random sampling of people being carried out by the REACT study and the ONS infection surveys, which I'm going to talk a little bit about later on. So who we've been testing has been changing all the way throughout this, not just how many people we've been testing. And we've had some significant events as well. Like I said, test and trace coming in, but also schools starting. When school started, there were there was anecdotal stories of a lot of students having to be sent home because someone in their class tested positive, and then they couldn't go back to school until they had, a negative test, or a student being sent home because they had a bit of a cold or a freshers flu, and they weren't allowed to go back until they had a negative test. So we found that all our testing was being inundated by all these people who were probably negative. And if we look at the testing capacity at that time, we see that all of this flooding of people who were more than likely negative was having such an impact on testing capacity. We reached the limits of our testing, and that meant that then people who were positives couldn't get tested. So we were testing our capacity. We're testing different people at all different periods of time. How are we supposed to use this information to infer anything about the relationship between these reported number of cases and the true underlying prevalence? This data, this case data, it almost becomes redundant for trying to get an idea as to what prevalence might be. Yes, it could probably give us an indication as to if we're moving up or down, but can we actually use it to infer anything really useful? I'm growing increasingly unsure as to whether or not we can. So can we use something else instead? Could we say, for example, use deaths as a proxy for case numbers? Death is a hard endpoint. There's been a few glitches, a few comparisons between government data versus ONS data that uses death certificates. The government changed its definition, so it hasn't been without its issues, but death is a hard endpoint. And is there a relationship between the proportion of deaths that stays constant throughout? So do we always see the same proportion of deaths corresponding to a certain number of cases? And can we therefore use death data as a proxy for overall UK prevalence? If we look at this death curve, it certainly looks more similar to what we saw for that prevalence curve before. We see this reduction going on here, and we do see that prevalence seems to be lower here than what it was up here. Does that mean we can use this death data? Well, unfortunately not. This also has its disadvantages in that the demographic of cases has changed throughout, and there are different risks associated with different demographics. If we, for example, look at the distribution of coronavirus cases amongst different age groups in the week ending the 10th of April, we see that actually it's fairly uniform among the 20 to sort of 79. There are some differences, but not huge amounts. And there maybe is a bit more of an increase in the over 80s. If we compare that to what we see at the weekend on the 25th of September, we can see that later on in this second wave, we're seeing much younger people getting coronavirus, whereas earlier on we were seeing older people getting coronavirus. And we know that there's a differential in risk versus the different age groups. The younger you are, the less likely you are to die from coronavirus, whereas the older you are, the higher risk you are. And so because the spread of coronavirus cases has been changing all the way throughout, unfortunately, we can't use this death data to give us a sort of proxy as to what might be going on with prevalence in the UK. Now, using this messy data, this messy rapid data to inform levels of prevalence in the UK is really difficult, and it's not straightforward, and especially in the changing landscapes, the situation's been evolving constantly. I think statisticians, we really have an important part to play in that narrative. I think this data, it's still great that everybody's being transparent, it's still great that we see it, but I'm not sure that, the whole number theatre of seeing these daily reported cases when we know that actually they're not a true estimate of the underlying prevalence, I'm not sure that they're the most useful. And it really needs statisticians to take that data and to really tease apart what might be going on and to try and gain some insight. I do think that there have been good instances of where, you know, the government press conferences and things like that have been trying to do that. But I will admit that there are a few issues that I've spotted in some of the things that have been said and some of the commentary and some of the narrative that we've been seeing. And I did want to just spend a couple of moments highlighting just, I think, two of my biggest bugbears, two of the things that have probably annoyed me the most so far during this pandemic. So the first one is concerning schools. And this is what Chris Whitty had to say on the 30th of September in the press conference.
It's important to differentiate between different age bands, between younger people, children, and young adults. And this is just to make the point, in the dark blue and light blue colours, we have children 5 to 10 and 11 to 14, and in green we have children aged 15 to 16. And in these groups, currently, the rates are actually really not changing very much. These are school-age children in the main. Whereas in older young children and young adults, in those 17 up to 21, and the same is true for other young adults, the rates are now going quite rapidly. I've chosen to illustrate it with slide positivity. I could have done this with other routes. So this is important to remember when people worry about schooling. Schools are one of the areas, school-age children is one of the areas where the rates are not going up. And this is true across the country.
Now, I'm not sure I entirely agree with that statement. So this was the graph that we were looking at, and it's the test positivity by different age groups. So we've got this 5 to 10, 11 to 14, 15 to 16 age groups that don't seem to be changing in their test positivity proportion. And what Chris Whitty said there was that case rates then didn't seem to be changing, and that was a positive thing because you know, we were worried about school children. That isn't necessarily true though. Let's think about test positivity, and I'm just going to assume test positivity is 10% just because it's a nice round easy number. I know it's an overestimate, but let's just assume that we're testing children and the test positivity remains 10% throughout. If you test 100 children, 10 will come back positive. If you test 1,000 children, 100 will come back positive. So you can have a test positivity that stays constant throughout a certain time period. But if you're testing more people, that means that more are going to be coming back positive, and your number of cases is actually going to be going up. Just going back to this kind of sort of relative risk versus absolute risk. So what were the testing numbers over this period of time? So the period of time that they were looking at was actually from the beginning of September towards the end of September, so the sort of 25th of September type time. What was testing over that period of time? So these are the number of tests that were carried out in the age groups 0 to 9 and 10 to 19. And if we look at these three time points here, we can see that actually the number of tests being carried out increased quite a lot, was going up. So yes, the test positivity rate may have been staying the same throughout. That doesn't mean that the number of cases that were positive stayed the same throughout, because the number of tests were going up. So I thought that that was quite a sneaky little interpretation of the data that told a narrative that I think was quite convenient at the time. There's another phrase as well that has upset me quite a lot throughout this, and it's exponential growth. And you see it being used quite a lot. And on the 21st of September, you know, you may remember we all saw this famous plot where we were looking at what would happen if case numbers doubled every 7 days. And it was an example of this exponential growth. And it was, you know, it was caveated that this was just a scenario. There was reason to believe that doubling was occurring between every 7 and 8 days, what would a 7-day scenario look like? And they said that by the middle of October, we would reach approximately 49,000 new cases, or 50,000 new cases. Now, in the press conference on the 30th of September, Sir Patrick Vallance was actually questioned about this. And here is what he had to say.
The illustration was to point out that epidemics either double or halve, they're either growing or shrinking, and doubling means that things go very big quite quickly. So things move quickly.
Now, this is the thing that's really annoyed me about this, that exponential growth seems to have just become this synonym of fast and a really bad thing. But exponential growth doesn't automatically mean fast. It's more concerned with the way speed is changing. The speed of growth is proportional to the size of the population. So let's think about rabbits. So 20 rabbits in a breeding population will give twice as many new rabbits as 10 rabbits in a breeding population. So the increase in rabbits is proportional to the number in the breeding population initially. You can't say that, say, year on year, we're always going to see an increase of 10 rabbits. The increase in rabbits that you see is going to depend on how big the population is to start off with. And that's exponential growth. The speed of growth is proportional to the size of the population. And I find it really helpful to think of exponential growth in terms of doubling times. Now, exponential growth, as I said, doesn't necessarily automatically have to mean fast. Something that is doubling with a doubling time of a day, that gets really big really, really quickly. But something that's got a doubling time of, say, 10 years, that gets big a lot slower. Exponential growth is just telling us something about the shape of the growth, not necessarily telling us that something's going to get big very, very quickly. We can actually estimate exponential growth and doubling times quite straightforward. So this is the new cases and the cumulative cases data, reported cases for the month before we went into lockdown. So from the 23rd of February, where there was 1 new case, and that took us to a cumulative of just 11 cases, all the way up to when we went into lockdown on the 23rd of March, where it was 2,327 new cases and over 12,500 cumulative cases. Now, we can use this to calculate what the doubling times might have been. And what we can do is we can look at the percentage increase for each day. And if we take an average of that, we find that on average, the growth was 28%. So cases were increasing by 28% daily. And you can do a little bit of maths that then tells you that that corresponds to a doubling time of between 2 and 3 days, which was what was being presented at the time. And we can actually colour these in. If we colour in sort of every third, we see round about that does seem to correspond to the sort of doubling time. It's never going to be exact, this is noisy data collected daily, but it does seem that we do seem to have, a sort of doubling time of about 3 days. Now, I don't want to say that cases haven't increased rapidly and they won't increase rapidly again, but I think that exponential growth shouldn't just be this blanket term used to scare people. This was a scenario of 7 days, and this was what it looked like. But we have different surveillance studies looking at growth rates and looking at what doubling times might be. And we can actually compare some of the different values that we get out and see what would that mean for new cases and how they increase. So REACT is an example of one of the national surveillance studies that's taking part. It's been hosted by Imperial College London with support from NAHR, NHS, various other people. And what they do is they are doing this random selection of the population that I talked about right at the very beginning, and using that to try and estimate the underlying prevalence in the UK. So they randomly invite people to take part. Volunteers are sent swabs and they get their test results, and they're using that to get an estimate of what the prevalence might be, what the growth is, and then what these doubling times might look like. And the latest publication that they had, they estimated that between 18th of September and 5th of October, there was a doubling of the virus every 29 days. And we have a confidence interval there of 17 to 84. So don't even get me started on the fact that we very rarely see confidence intervals and uncertainty. That's a whole different talk. But here we have a doubling of the virus every 29 days. So these different doubling times look like? I think it's really difficult to try and comprehend what would that mean for how cases increase. And I think that's why the government showed this plot, because exponential growth can be difficult for people to grasp. There's a well-known exponential growth bias where people underestimate it. So by visualizing it, we can see what's going on. But I think it's helpful to visualize different values and see how they can affect different scenarios for increases. So this was what the government presented. They had their number of cases up until the middle of September, and then they projected their doubling every 7 days. So this is what our projection looks like for 7 days. And this is what our projection would look like if we had a doubling every 29 days. So by the time we get to the middle of October, we had about 50,000 cases, new cases daily, if we were doubling every 7 days. If we take it to doubling every 29 days, we're at 6,200 cases daily. So very, very different values by the time we get to the middle of October. If we were to go up at the same speed that we had right at the very beginning of the pandemic, where we had doubling every 3 days, it would get very, very big, very, very quickly. And by the middle of October, we'd have actually had 1.3 million daily cases. But I think it's really important to note that they said at the time that they thought that the doubling was happening between every 7 to 8 days. And they chose to just present this 7 day as a scenario, as I said, with no measure of the uncertainty or no idea as to how slight changes in that could affect the different estimates that we get out. And using a 7 day doubling time, we got around 50,000 cases, new cases a day by the middle of October. If you'd actually used an 8 day doubling time instead, it's still a large number, but we'd have been at 35,000 new cases every day. That's a difference of 15,000 cases, just to the doubling time of either 7 or 8 days. So not having any sort of measure of uncertainty or how these can be affected by different numbers, I think is sometimes unhelpful. Incidentally, this is what we actually ended up with. So we can see that, because what we've got in this little bit here was the the well-known Excel glitch. So actually this curve probably should have looked something like this. So it did look like we were having this doubling of sort of every 7 days or so. But now we've had these, local lockdown measures, not meeting of households and things like that. It does look like the doubling time does seem to be coming down. So I've talked about the REACT national survey, and I am coming to the end of my talk, and I just want to finish off by talking about these national surveys that are trying to get a handle on what the prevalence might be, bring it right back to our initial question of how many cases are there in the UK right now. And we have this REACT study that is inviting random people to take part and using that to get an estimate of prevalence. The Office for National Statistics, they're also doing an infection survey where they're looking at households who have previously taken part in other ONS surveys, and they're inviting them to be screened for it. They're also doing home visits and are offering reimbursement. So maybe they may be more likely to take part, but they're not necessarily as random a sample as the REACT study is. If you look at the prevalences that you get out, they do get out slightly different prevalences. So looking at the period 18th to the 5th of October, REACT said that they thought there were 45,000 new infections a day, whereas ONS for a similar time period, just slightly delayed, 25th of September to the 10th of October, they thought that there was about 17,200 new infections per day. So they do get different prevalence results, but that may be due to the different sampling strategies that they have. The ONS survey, though, because it's looking at households, they have on average 2 people from each household. So there might be actually some really nice work could be done looking at spread within households, within household transmissions, as well as between household transmissions, which I think would be a really interesting piece of work to look at. But what do ONS say about prevalence? They produce this prevalence data, and their projection is that actually the true underlying prevalence within the UK looks something like this for this period of time, with associated confidence intervals. And as we can see that, we are underestimating the prevalence in the UK, by looking at these number of cases reported, but actually we don't seem to be doing too bad. We're not too far away. And as I said, if you ignore the glitch that we had with the Excel spreadsheets, the curve, for the prevalence does seem to be sort of mirroring what the reported cases are saying. So maybe there is an argument that actually now we're getting better at testing. You can actually use the reported case data to give an indication as to what might be going on in the UK. But can we compare it with what was going on in the first peak? Absolutely not. Testing is so different now compared to what it was back in April and even May. We just can't use these daily number of cases to compare the previous peak. You see these headlines saying we've hit this many cases for the first time ever, but actually the prevalence nowadays, these few months is probably a lot less than the prevalence that we saw. And just here's what Sir Patrick Vallance had to say.
I do want to just make one comment though, which is quite important to understand when looking at the numbers of cases. The number of cases that we're seeing now are picked up because there's much more testing. The number of cases that are reported in March were almost certainly a very big underestimate of the total. So it's much more likely that back in March and April, at the peak of this, we were seeing over 100,000 cases a day at certain times. Whereas, of course, you were only able to measure and report a fraction of that. So it's not a direct like-for-like comparison.
So back in March time, we may have been seeing 100,000 cases per day. I don't think we're seeing anything like that now, even though our reported peak is higher this time round. So, yeah, I think COVID has been a unique opportunity. There is definitely challenges around dealing with this messy data. As I said, we're in a pandemic that's brand new. The situation's changing constantly. We're learning more about it. Our capacities for testing is changing. And there's so many other things that I haven't been able to talk about. Things such as the quality of the data. There's always this weighing up to be had between data that you can get really quickly that we know is messy, but data that takes longer to come through, but we know is a lot more credible. The differences between the reported deaths versus death certificate data that takes a lot longer to get through. These prevalence estimates that we have these sort of 2-week delays on them versus this case reporting that we get daily. There is this balancing act to be had between what data do we want to use and what do we need to use quickly because it gets reported a lot quicker. There's also risk that I haven't even talked about. There's been some work done quantifying the fact that risk changes for different age groups, different ethnicities. David Spiegelhalter has produced some of these graphs that you might have seen where he was comparing your risks of death from coronavirus with your annualized mortality rate, and actually how they seem to be quite similar to each other, and that actually deaths, your risk from death from coronavirus actually went up and mirrored the same sort of risk profile as just annualized risk dependent on age. Regional and demographic variation. So I've just started working with ITV. I'm going to be the sort of coronavirus statistician over the winter, and I did a little piece looking at how much were students driving surges in UK cases. So within cities, looking at student areas versus non-student areas, and seeing that actually a lot of increases in cases in cities were being driven by increases in cases amongst students. Our numbers, which we've all seen a lot about, excess deaths, which you may have seen quite a lot about, and I think there's something really interesting going on at the moment. If we look at those people who are dying in hospital, where we're now seeing fewer than expected deaths, and those people dying at home, where we're actually still seeing more deaths. So it seems like we're switching from deaths in hospital to deaths at home. And whether or not there's a conversation to be had over not just numbers of deaths, but maybe quality of death. You know, are people dying from at home rather than in hospital because actually, you know, maybe their families can't come visit them or something like that. And I think, yeah, there's a big discussion to be had here of excess deaths and quality of death. Test accuracy, so sensitivities and specificities of tests, which are going to become even more important as we start seeing these rapid tests, you know, 5-minute tests, and you know, the mass testing that the government would like to bring in. Country comparisons, you know, we saw right at the beginning lots of country comparisons, and some of the pitfalls behind that, you know, the fact that we've got different demographics in different countries, but we could still learn some things about curve shapes and different policies that people brought in. And then also finally, which is, you know, probably the bit that I'm really interested in and working on actively, working within the clinical trial world, is clinical trials for vaccines and for treatments, making sure that any treatments or vaccines that we get on the market are going to be both safe, but also effective. So to finish up, I would say that good statistics don't just appear in society, and I think just having the data alone doesn't help us make informed decisions. We need that narrative. We need to be able to tease apart what's going on, and I think statisticians have been and will continue to be essential in this fight against COVID. And I hope that maybe a silver lining of this pandemic is that people will have a new appreciation of the value and the importance of numbers. And it's lovely to hear people talking about stats and leaning on stats to try and lead the way through this. So I'd just like to finish by once again saying a huge thank you for giving me this award. It really does mean a lot. Yeah, thank you very much for your time.